Thank you. So I'd just like to say actually that it's great that Malcolm's come today, and we're grateful for him doing so. And I think we have been able as a community to effect some changes that reflect the issues around clinical practice, and you've alluded to a few of those, and we're very grateful for that. I think annual updates are better than no updates, and I guess my point was, as I think came from the room, when you're looking at individual prescribing, it would be good if there was a more real-time solution to that. So I was asked to talk about multidisciplinary teams, and obviously some of the previous speakers have already alluded to this. In the interest of transparency, these are my disclosures, which obviously means from previous talks that I won't be asked to contribute to any nice reviews. This was my objective. So to define what a multidisciplinary team meeting is and how it can be used locally, regionally and nationally to reduce variation in the prescribing of MS disease-modifying treatments, although as we've identified already during the meeting, managing MS is much more than just the drugs, and I'll allude to that a little bit. So this was my sort of conceptualization, if you like, with the patient in the centre. And the so-called coordinated MDT from our last iteration of the NICE clinical guidelines, and obviously every patient should have that coordinated MDT potentially. And then the more restricted, perhaps DMT patient MDT. We have a minimum MDT, which Malcolm's alluded to, and I'll define those in a moment, as the algorithm did. And then what we've termed in some of the meetings that we've done, for example, at the last Northern Update meeting, about the evolving MDT. And then finally, that wider clinical network that we all need now to fall upon, or to rely upon rather, in relation to manage our patients effectively with treatments that have adverse effects outside of our areas of expertise. So this was the coordinated MDT from the last set of NICE guidelines, 186, and just to make it slightly easier for you at the back, then essentially this is what it suggested. So consultant neurologists, MS nurses, physiotherapists and occupational therapists, a whole host of allied healthcare professionals, access to speech and language therapy, psychology, and so on, and the general practitioners. And we've started to talk a little bit about the variation in terms of the involvement of general practitioners in our patients' care. And then, as the previous speakers have discussed, there's been the gradual evolution of the DMT algorithm, and I can appreciate some of the logistical issues that arose. The initial meeting, I think, towards the end of December 2016, the multiple drafts that were in circulation. I think one key piece of feedback I would give you is the communication channels in which we are communicated with, and I think that's really important. So I know in our centre it doesn't necessarily work in the way that one would think it should work. And it would be good if there was some central repository really that we could all go to, a website with an updated version of the latest version of the algorithm and so on. And if they are under consideration, then obviously again it would be good to know by which date we'll have that clarification. And of course all number of things happened during this period. The revised McDonald's diagnostic criteria, the NICE approval of various drugs, and in relation to the title of my talk, with cladribine tablets, the requirement specifically on the Bluteq form, ahead of the published algorithm, for an MDT discussion and a tick to say that you have formed an appropriate MDT and you've discussed that patient before you sign the form off. And then obviously various other changes in terms of DMTs. So the algorithm that was published that WACAR referred to, the stated purpose was to provide a framework to aid decision making to help reduce excessive variation in practice and to ensure safe and effective prescribing. So this is the minimum MDT for any prescribing service as stipulated in the MS Drugs Advisory Group algorithm. So again, an MS specialist consultant neurologist and at least one MS specialist nurse, and they make the point about having individual or team responsibility for the governance and the safety of monitoring at that particular centre, and then also linking in to specialist MS centres and their MDT. So for any disease-modifying treatment, this is the minimum. And then there's the minimum, as Malcolm alluded to, MDT for what the committee termed complex cases, or so-called higher risk DMTs. And this is where things start to widen out a little bit. So again, we have now at least 2 MS specialist consultant neurologists, at least 1 MS specialist nurse. They refer to access to neuroradiology, and they also refer to neuropharmacists and other specialist healthcare professionals being available. And again, that accountability of an individual or the team responsible for the governance and the safety monitoring. And this was the result of a meeting that we held around 12 months ago, one of our Northern Update meetings, and I know there were MS team coordinators in the room, and we were discussing the issue around the emerging, in practice, the emerging MDT for a patient receiving a DMT. And in addition to everybody that we've already cited, the MS team coordinator and the administrative support for what is an increasing burden, administrative burden in terms of using these drugs, I think is absolutely crucial. And this is the wider, or this is my stab at the wider clinical network for MS DMT patients. The specialities in other areas are not particularly ranked for any particular reason. It's just to sort of squeeze them into the diagram, if you like. And I think one of the issues for us is that when patients are in extremis, they tend to attend their local hospitals in a hub and spoke model, which is the model that we have in Manchester, as somebody mentioned yesterday. So building that clinical network of peer-to-peer support. So for example, your local haematologist in your centre to the local haematologist to the patient can be extremely useful, save time and facilitate management. And again, it's not always, as we found, it's not doctor to doctor all the time, it's specialist nurse to specialist nurse and so on, and really whatever works. But this is something which I think we are obviously all going to have to grapple with increasingly over time. So where are we currently? So we undertook a piece of work which was kindly supported by the MS Society with the University of Manchester, and some of you in the room will have contributed to this piece of work and also the national survey that I'll refer to in a moment. And if you did, thank you very much indeed, and I hope you'll be interested in the results. We presented the first one as an e-poster at ECTRIMS last year, and the national survey at ECTRIMS this year as a poster. And so we were looking at factors influencing DMT prescribing rates and practices, and we started off with a qualitative study of neurologists and MS nurses. And so these were semi-structured interviews, all conducted by a single researcher, Elaine Cameron, with a mean of around 1 hour. There were 34 participants, which for thematic framework analysis, I think is a massive undertaking. So ordinarily, an N of 6, for example, would be considered to be a satisfactory sample. And we had 15 sites, 7 which were classed as specialist sites, 8 as non-specialist sites, and you can see the breakdown: England, Scotland, Northern Ireland and Wales. And that reminds me that we had colleagues in each of the home nations, so James Overell in Scotland, Owen Pearson in Wales and Gavin McDonnell in Northern Ireland, in addition to myself, acting as regional coordinators, if you like, for this study, and that was very important. And so there was qualitative thematic framework analysis, which broadly speaking requires looking at the data, trying to understand it, labelling it, indexing, charting, and identifying patterns. And what we found was that the UK prescribing guidelines are perceived by neurologists as open to interpretation. Some colleagues felt that relapses were not particularly well defined. I suspect there'll be a few pulled faces there, because obviously the algorithm does largely transpose the definitions of the various types of relapses, clinically disabling and clinically significant, and disabling, and so on. And that neurologists can influence by local prescribing cultures in organisations and peer networks, and that could be positive or it could be negative, depending on your view and obviously the necessary outcome. So as one colleague said, you tend to have certain neurologists who are more dominant and perhaps influence the department. And then there really came to the fore this issue about concern around potential long-term side effects, for example, malignancy, in relation to the use of some of the higher risk drugs. And one colleague said, the risks worry me, the uncertainty about a particular person's MS and how that will turn out to be. I don't sell any of these drugs as wonder drugs. So we identified 5 themes which influence prescribing: the determination of eligibility, the prescribing readiness, and the cautiousness. And I've alluded to some of those reasons in the previous point. Making the prescribing decision itself, supporting the patient's disease-modifying treatment choices, and then the influence of DMT prescribing peers in your locality. And so we took those 5 themes and then we designed a questionnaire with 51 items, which was online, and that was circulated between June and August 2017, precisely at the time that the WannaCry attack affected the NHS, if you remember, and corrupted the URL links and caused all sorts of other issues. So I suspect that's in part at least why we had the responses we did. So in summary, we had 46 responses. You can see the breakdown by the home countries, and you can see the breakdown by specialist neurologists. In this case, 3 were single-handed DMT prescribers. For anonymity reasons, we didn't ask for more demographic details than that. Now, this one may not project very well, but this is the relapse eligibility criteria for DMTs utilised by the respondents, and you'll see in red, that's any relapse. So for those prescribers, they felt that they weren't too concerned whether it was defined, as we've said before, as clinically significant or disabling. Biologically, they're the same thing. It's a relapse. Evidence of new MRI lesions was sufficient to determine a relapse. That's in blue. And then clinically disabling in green, and the purple next to the green is a disabling relapse. So you can see there's variation in interpretation of relapse criteria. And as one person said, they felt that was really the largest contribution to variation in prescribing, the interpretation of relapses. So the commonest factors for determining DMT eligibility: time since last relapse in a third, MRI disease activity in a quarter, and around 2/3 of colleagues scanned patients before a DMT decision, and about 1 in 5 people felt that impact on patients' daily functioning was of concern. So we defined what we called a borderline case for active RRMS, 2 sensory relapses, 23 months apart, rapid and full recovery, and no new MRI lesions in the preceding 2 years. And under those circumstances, about 2/3 of the neurologists that responded in England felt that they were somewhat or extremely likely to recommend a DMT, about a quarter in Scotland, 40% in Wales, of what obviously is a small sample, and just one of the 2 neurologists that contributed to the survey in Northern Ireland. And in terms of the multidisciplinary team clinic, so again, this was last year now, and obviously this is an evolving phenomenon, but you can see basically that only about 18% of colleagues that responded, and it may obviously be a self-selected sample, didn't have an MDT at the time, but there was variation from weekly through to monthly, through to some occasional times during the year between different centres. So how can MDTs reduce variation in prescribing in the future? And I purposely haven't changed my slides from before the meeting, but these were some of the thoughts that I had. The algorithm does make the point about regular communication, or the preamble to the algorithm makes the point about regular communication. So I've included this point around the MDT being a potential conduit for that communication. And again, the interest group make the point about the necessity for audit, for quality control, and for education. So locally, prior to the MDT, I think it gives the opportunity for improving education around eligibility for treatments, as far as we understand that, and benchmarking around local prescription rates. So are we working in an area, for example, where we find that local prescription rates are below the national average? And is that something that, that other colleagues that are referring into the disease-modifying treatment clinics initially, and then presumably then onto the MDT at some point, will take on board? I think improving the network of MS nurses, we've heard obviously from the MS Trust in relation to that, and together with employment rights, and I've put that in inverted commas, because I think it does vary from place to place. We did an audit in our practice a few years ago. Half of the patients referred to the DMT clinic came from the nurses. If the patients had been seen by a nurse and referred to the clinic, they were better informed, they had the information about the DMTs, and they felt more satisfied with the whole process than if they'd been referred by a neurologist. So what we tried to do in terms of closing the audit loop was say to our consultant neurologist colleagues, we're not expecting you necessarily to do any more work other than please, 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 when you refer into the DMT clinic, please copy in your local MS nurse, and the MS nurse will do the rest and ensure that the patient has the appropriate information and so on. And again, that could go back to the patient directly in terms of DMT information that then helps the patient arrive at a decision in a more streamlined fashion. And I think feedback to referrers is always really important, and particularly if the patient isn't eligible for DMTs at that particular point, then a management plan, and we started to talk around environmental factors and modifiable environmental factors, including smoking, which obviously continues to demonstrate adverse outcomes in people with MS. So I think at the MDT itself, I think subsuming the DMT prescribing responsibility to the specialist clinics rather than to generalists will reduce variation. And we know that some centres do have every neurologist being able to prescribe every DMT. Forming an MDT obviously is likely then to harmonise, I think I've called it here. Yes, identify and harmonise outliers. I was trying to think of a word for that, and I think in practice a number of centres I think have formed an MDT even ahead of the requirement to do so, to try and harmonise the approach across multiple prescribers. Benchmarking prescribing of second and third line DMTs, including criteria for switching, I think has been alluded to in the previous talks, I think is going to become increasingly important. And there's also the issue, the infrastructure issue around secondary reporting of scans. So again, discussions with colleagues where scans have been reported by a general neurologist or scans have been reported by a private provider that has been contracted by the trust to increase capacity. There is a necessity, I think, amongst a lot of colleagues to get those scans reported again, which obviously puts more stress and demands on local services, but to get a local neuroradiologist that you trust in terms of the opinion. And again, anecdotally, from discussions, issues around eligibility change not infrequently when the scan has been reported by a dedicated neuroradiologist. And again, this point about audit, quality control and education, and again, at a regional level perhaps versus a national level. And then following the MDT, I think defining the next steps in management and actions is really important. So again, being able to standardise the pathway in which patients are managed. And as we've already talked about, the issues of dealing with the administrative burden in terms of bloods and MRI scans and everything else. And I think that's important to try and make sure that the patient is aware of what's going on and also other colleagues. And then reviewing the patient at some point after a period of switching and escalation and rebaselining and so on, I think again can be coordinated through the MDT and some standardisation of approach. And again, this point about feedback and continuous improvement and benchmarking our practice and our outcomes, which has been mentioned a few times, against our colleagues. So I think regional variation, again, I think this is very similar. The only difference in point I wanted to make was the single-handers or the smaller centres with less experience in prescribing new DMTs, aligning with larger centres, possibly trial centres. So I think for those of us that do trials that have been involved with phase 3 and not been involved in phase 3, I think the experience is completely different actually for new therapies. And as I said, that second and third line is really important, and the rest are very similar. I think there is a possibility at a regional level, though, for preceptorships and training of colleagues in other centres, perhaps with less experience, and infusion nurses, I think, would be a good point for that. So just finishing off very quickly, reducing national variation, I think the argument that we had, or the discussion that we had at the end of Malcolm's talk, I think a lot of it is around infrastructure. And I don't see that we get additional resource for being specialised neurological centres. We've had the infusion tariffs for 10 plus years, and I think with the exception of one centre, I think nobody has managed to make a successful business case to actually get additional resource, and particularly administrative resource, into the department as a result of those extra funds. And I think that's where the link the link has been broken, as it were. So I know other colleagues will talk about data and potentially registries. I think support, so again, financial administrative support for local and for regional DMTs, MDTs are going to be very important. And then this point about collecting this basic core data set, and again, we can talk later on about some of the practicalities and the issues about that. I just wanted to finish off with this point about the law of unintended consequences, and it's already been pointed out that with good intentions, perhaps we're asked to collect additional pieces of data. And I guess all I would say to the people in the room that sit on the panels, and I'm sure they do consider this, but again, just to reiterate the point, please think about the additional burden that places, that one extra data point places on an already overburdened service and the administration. I thought I'd finish off with some local figures. So on the left, you have the number of patients with MS that are known to the regional Greater Manchester service. At the end of December 15, we finished the GEM study with MS Trust, and we've had about a 6% year-on-year increase in patients known to the service. What about the cumulative increase in patients on disease-modifying treatments? If we take 2013 as our baseline year, so 100%, there's been a 60% increase in the total number of patients on DMTs in Manchester over that time. And obviously the resource hasn't matched that additional increase. And then if we look at the breakdown, you can see that from 2013, where we only really had injectables and one monoclonal antibody, through to today, we've had a drop down, so we still have a large legacy patients on injectables. We do use a lot of glatiramer, as it happens, for various reasons. The monoclonals, although the percentage breakdown has remained pretty flat, I've already shown you that there's been a 60% increase in the total number of patients over time. So in fact, that has increased to about 30% of our recent prescribing. So with that, I hope that was a whistle-stop tour about MDTs, and we'll give you some opportunity for discussion in the breakout groups later.
So we're running out of time before lunch. I've been told we're not going to be able to do questions on the MDTs in this session. We'll have to do them this afternoon when we do it. So Jerry, if I can ask Jerry Cliff to come up. Thank you. Thank you, Glenn.